this morning.
Great.
Five today. Oh, I like that there.
Yeah, it's definitely different. So this is intimidating back row. Okay.
Yeah.
Very intimidating.
Yeah, I'm still trying. I am listening. Exactly. That's all you can do. I have not even followed up. Like they've been sending me.
I'm a messy. It's gonna be mad if there's not.
It is.
All right, let's go ahead and get started. It is my distinct pleasure today to introduce Dr. Anand Parekh, who is the Chief Health Policy Officer at the University of Michigan School of Public Health, as well as a Senior Advisor to IHPI. He is the former Chief Medical Advisor at the Bipartisan Policy Center in Washington, D.C., where he provided clinical and public health expertise from 2015 to 2025. Prior to joining the Bipartisan Policy Center, he completed a decade service at the U.S. Department of Health and Human Services, including serving as HHS Deputy Assistant Secretary for Health between 2008 and 2015, leading national initiatives focused on prevention, wellness, and prevention. Dr. Parekh is a board-certified internist, an adjunct professor of health management policy at the School of Public Health, and an adjunct associate professor of medicine at Hopkins School of Medicine. Thank you.
Thank you, Dr. Chua, for that introduction. It's great to be here. Heard just amazing things about CHEAR and from Cow, and ready to learn more and learn about the important work that you all are doing and see how I can be helpful to all of you. So my talk today is sort of an understatement, perhaps, if you look at titles, understatement of the year, health policy in an uncertain environment. Clearly, that given that we're at the federal level, still government shutdown, even though it appears that there may be a way out of this. Of course, from a health perspective, that may not include an extension of the expiring advanced premium tax credits. But yet that is at the heart of the shutdown over the last 41 days. And certainly, I think that uncertainty, along with what's happening at Health and Human Services, with RFK Jr., DOJ, OMB, the impacts on federal agencies, certainly, I think, a very uncertain environment. So what I thought I would do is just spend first a few minutes, provide my perspective based on my experiences sort of going into what I'd like to see sort of health policy focus on, and then get into exactly what's happening now, touch on some of the high level issues and that we've all been hearing about. And then I think most importantly, just want to engage in a dialogue and discussion with all of you. So I think we'll have ample time for Q&A. Perfect. Yeah, thanks. So my journey started here at the university over 30 years ago. I was in political science, and then I spent some time at the public health school in the Department of Health Management Policy, did my medical school work here as well, but always very interested at that intersection between government, public health, medicine, trained at Hopkins in internal medicine, and started to see patients. But what was getting me up really in the morning was the question that many of you also have: how do you make a change on a broader level? Even though it was satisfying seeing one patient at a time, the possibility, opportunity of helping hundreds, thousands, or millions through health policy, even though a little bit more indirect, what was really appealing. And so I started at the U.S. Department of Health and Human Services in the Secretary's office, where I spent 10 years there, initially focusing on public health emergency preparedness. So this is post 9/11, where H5N1, actually avian influenza preparedness, was a focus, as well as bioterrorism preparedness. And then with time moved to more sort of broader public health policy related issues, in 2009 and 10. Recovery Act, Affordable Care Act, of course, passed and really then focused in on chronic disease prevention, where I've sort of spent half of my career, and then chronic disease management. So I led for HHS our initiative focused on individuals with multiple chronic conditions and how you improve their health status and quality of life. And so I spent 10 years at Health and Human Services, wanted to stay engaged in federal policy, but wanted to be outside of government, and joined a very sort of unique think tank in DC, particularly with its first word, the Bipartisan Policy Center, which was formed in 2006 by 4 former Senate Majority Leaders, 2 Democrats, 2 Republicans. The whole idea being that let's take the best ideas from both sides to promote health security and opportunity. And as Kyle said, I served as chief medical advisor. That organization is very much focused on the legislative branch in Congress. So if you think of a 3-legged stool, the way we operate it is identify a really important health policy issue. Second, an issue that both sides of the aisle need to be educated on. And third, from a political science perspective, an issue where there's some sort of policy window. Some policymaker cares about it. So something's up for reauthorization, something needs to appropriations, something is a key priority for a new administration. And then we did policy research analysis and provided recommendations to Congress. So that's where I spent the next 10 years. And now, sort of after those 20 years, coming back to the university, as Kyle said, in this new role at the Public Health School as Chief Health Policy Officer and at IHPI as Senior Advisor. Really, the role is to help the university translate the care practice research happening to policymakers to drive positive health impact. And so I have 3 audiences. The first, governmental policymakers, so that's both DC as well as Lansing. And so working with public health, Michigan Medicine, their Office of Government Relations, they're there. The second audience is the public, because I think, and probably many of you will agree, the biggest challenge in our profession today is rebuilding trust in public health science and medicine. And so how do we better connect with the public? And the third is to develop partnerships, and particularly for the public health school and for many schools, diversifying funding streams and funding partnerships, given what's happening at NIH and CDC. So that's sort of the role that I'm stepping in to help the school and hopefully the university more broadly. So that's a little bit about my journey. So the perspective I have very, very broadly, and I pick life expectancy as sort of one example of sort of what sort of gets me going in health policy. I think we know that for the last 15 years or so, we've seen stagnation in life expectancy in this country, which is atypical for many of our peer countries. And even prior to COVID, we had this stagnation. In fact, between 2014 and 2016, we had the first 3-year decline in life expectancy since the 1918 Spanish flu. So that was between, again, all of this occurring before COVID. There are a number of key preventable factors leading to the stagnation. Probably the most important is this plateauing, the decline in mortality rates from cardiovascular disease. I think as tobacco use has come down, obesity has gone up, and then the implications there for many of the chronic diseases we're facing. Obviously, the opioid epidemic, diseases of despair, has been a part of that as well. And then, of course, COVID happened. And then, even when we fell, as you know, from COVID in terms of life expectancy, more than many of our peer countries, and the rebound has been slower as well. Certainly, we have disparities that exist by income, race, geography, and again, we could have selected infant mortality here and similar stories, but this sort of speaks to the urgency of where we need to focus if we want to improve on health status measures. Geographic variation, so there's lots of variation here, but this is an example, a slide study CDC did a number of years ago, where they looked at the best states when it comes to the 5 leading causes of death and mortality rates. Who's doing the best? Who's doing the worst? What if the worst states could do as well as the best states? How many potentially preventable lives could we save, or how many potentially preventable deaths are there? And this is, again, from a little while ago, about 250,000 potentially preventable deaths. So just again, an indicator of how much better that we can do as a nation. So, and then we, of course, over the last, at least from 20 to 24 went through COVID. And this study from HA just reminds us of the connectivity here between infectious diseases and chronic diseases. So 2/3 of COVID-19 hospitalizations are thought to be attributable to 4 major US cardiometabolic conditions. And so even if all you cared about was infectious diseases, it's critical that the underlying health status, very much driven by risk factors of chronic diseases, are tended to, and vice versa. So that connectivity is, slide provides that reminder. And then, of course, we know sort of what happens within the clinical setting is important, but what happens outside the clinical setting is arguably even more important. Lots of sectors that are there that are critical there, including public health. In terms of more broadly social services, we know from global data that the ratio of what countries spend on social services, whether it's housing or education, transportation, versus what they spend on healthcare matters. And here on the left, you see that we've always been an outlier, sort of this 2-to-1 ratio that most other countries have in terms of what they spend in social services, healthcare services. For us, it's sort of 1-to-1 because we spend so much on healthcare. And the ratio matters if you just look at states across the country, and you look at state GDP and social service and public health spending versus healthcare spending. Those that have a higher ratio have better health outcomes. So they have less obesity, less asthma, less mortality rates from MIs, diabetes, and so a number of factors again. And again, this is all things that we know, but just sort of remind us about the importance of prevention. And so I think that the big question for me after sort of the public service and then Bipartisan Policy Center was, well, we all know that prevention is important, but just why hasn't it been prioritized? And I think that was really the question that was bugging me all my time in Washington, D.C. And so here are a couple of reasons, and I outlined this in my book, Prevention First: Policymaking for a Healthier America. The first, based on my experiences, DC is a very reactive town, right? So it's sort of one crisis after another. Sometimes these are manufactured crises. To really focus in on prevention, you got to be proactive, right? And so if you're reactive all the time, you're never going to have enough time for prevention. The other thing about prevention is it requires patience. You're not always going to get a quick win, and sometimes it can take years. It can take decades. And that for sort of policymakers, when they want quick wins and they want to demonstrate for various reasons, whether it's for reelection or others, that they've made progress, it's hard to sort of square. Again, a lot of times when it comes to prevention, you've averted something, right? It's hard to, that win may be invisible. So something bad has not happened. And that also sort of makes it difficult for a policymaker to see the win, a win. Oftentimes, just policymakers don't understand the evidence behind whether it's prevention or aspects of public health. And then if you don't understand those aspects, then you can quickly start to, believe stereotypes or, nanny state arguments is sort of just one example here. The elusive mandatory dollar and limited discretionary dollar. So the vast majority of what we spend in healthcare, at least at the federal level, is all Medicare, Medicaid. So it's mandatory dollars. Very difficult sometimes to extract resources focused on prevention. Most of it, as we know, goes to treatment. And then there's relatively limited discretionary dollars. And it's always then a fight in terms of how to allocate resources. We still don't have people talk about this a lot, sort of a true healthcare system. It's largely a system where individuals with preventable conditions are coming in with complications, again, that could have been averted had we worked earlier. So, and the way we pay, even though for 20 years we've been talking about value-based healthcare transformation, we are still very much predominantly in a fee-for-service system. Obviously there's been movement there, but not easy necessarily to make money from keeping people healthy. An area that we need to accelerate our focus. And then a lack of a grassroots movement. And it's interesting, to a certain extent, sort of making America healthy, again, let's just take out the word again, but that should be sort of a unifying piece and theme focused on prevention, but we can get into why that has gone in a bit of a different direction. But again, no grassroots movement. So nobody was coming to our office at HHS or going to the Hill and say, all right, well, we're gonna focus on prevention. And there are groups out there that do that, but again, not that grassroots movement. So a whole host of reasons, I think, based on my experiences and reflections of why what seemingly should be straightforward is not so straightforward when it comes to policymakers. And I think at the end of the day, we also have to say that of the $5 trillion we spend on health in this country, the very areas that we think we all know we need to focus. I always talk about the 4 Ps. If you want to improve population health, you got to focus on prevention, public health, and primary care. And these areas, so in prevention, primary and secondary prevention, the best estimates are we spend about 5% of that 5 trillion on prevention. Public health, this is very generous based on national health expenditure data, but maybe 3% on public health. And on primary care, the foundation of any successful healthcare system, we spend about half of other OECD countries. And these 3 categories are not mutually exclusive. So there's a lot of overlap. So ultimately, how we spend our resources, I would say, define our priorities, and our priorities define our values. And so the question, I think, for the country is really how healthy of a country do we want to be? I think we know what we would need to do. The question is will we do that? And I think that's a central question for all of us. So a little bit of a segue in terms of key issues as I see it right now, health policy in this uncertain environment, and then I would really love to open it up to everyone. So certainly at the federal level, sort of the big elephant in the room is MAHA, Make America Healthy Again. Unclear in terms of temporal piece there. You know, at what point in history are we going back? But really a movement that at first was focused on reversing the chronic disease epidemic, but now sort of narrowed into children's chronic diseases. But really sort of a select group of issues, if you will, and many niche issues. Hopefully you've all seen the MAHA both assessment as well as strategy, focused in 4 areas. The first related to nutrition, a lot of focus there on aspects of additives in food, dyes in food, obviously the processing of food, the need for definitions of ultra processed food. Less we're hearing about really going after the hyper palatable elements of food that are really driving chronic diseases. You think about sodium, you think about added sugars, you think about saturated fat. We're still waiting for the dietary guidelines for Americans that should come out later this year. So a heavy focus on nutrition, as there should be, for a variety of reasons. The second, environmental exposure. So really what's being laid out looks like a research agenda across a host of different areas. Somewhere we need more data and research, whether it's PFAS or microplastics. Other areas where there's just not a lot of discussion, whether it's lead, whether it's asthma. Of course, a focus on fluoride, where again, it seems like policy is getting ahead of the research, but sort of a bit of a mixed bag. Pesticides as well, and then some of the things in the strategy and the assessment also don't align. A third area, a little bit of a hodgepodge, focused on mental health, social media use, stress, sleep, physical activity, presence, fitness, a whole hodgepodge of areas there. Focus on children's health, and then a final one on over medicalization, which is really a combination of on the psychiatric care side, overdiagnosis and overprescribing, as well as then almost sort of an opportunity for the agenda for the movement to take on those who are opposed to vaccination. And I think we've seen sort of the efforts by the current administration, from the disbanding of ACIP to the changing labels of the COVID vaccine and the recommendations from CDC related to COVID, childhood vaccination recommendations, concerns about the implications of the Vaccines for Children program, reductions in vaccine research, particularly at NIH related to hesitancy, suboptimal uptake. So lots of course, concerns there that I think we've all been talking about and discussing on the vaccination front, but that's part of that fourth plank of MAHA related to over medicalization. Beyond sort of MAHA, and then when you bring in Congress, the other sort of reality of the federal landscape is what has happened over the last many months in Congress as part of the One Big Beautiful Bill Act. Part of the pay for was up to $900 billion over 10 years in Medicaid cuts through a variety of mechanisms, both reductions in payments to state Medicaid programs, through reductions in provider taxes, also work requirements for able-bodied adults, which would start in 2027. And the idea there being that eligible folks falling through the cracks, there'd be a reduction in enrollment, and that's how you'd save money. So work requirements, reductions in payments, so Medicaid spending cuts. There were also a couple of provisions in the One Big Beautiful Bill Act that made it harder to retain insurance through the individual market as well. So it's projected that up to 10 million people may lose insurance through that. And then, of course, what the shutdown was all about for the 20+ million people getting their health insurance through the marketplaces, the extension of these expiring premium tax credits, which has not happened, which if it doesn't happen would not only raise premiums for tens of millions of people, but at least, it's projected by the Congressional Budget Office that up to 3.8 million additional people could lose insurance. So you're talking about potentially 10 to 15 million people losing their health insurance, which is not quite half, but almost half of where we were pre-2010 before the Affordable Care Act, which and right now in our country, we are probably close to the highest in terms of insurance or having health insurance in this country, probably around 92-93%. Here in Michigan, we're closer to 95%. But you can see that what we may experience over the next few years are reductions in health insurance coverage, and we can talk a little bit more about that. Yeah.
So what's the projection for Michigan based on that national estimate?
So if the tax credits, we have about 500,000 people right now who benefit from tax credits in the insurance market. So a small proportion of those would lose insurance. The rest would have higher premiums if these aren't extended. And then in Medicaid, I can't remember the number off the top of my head, but certainly that, and again, it all depends state by state what happens with work requirements and state directed payments. A lot of this will also happen over the next few years. So work requirements don't have to start till 2027. You could get an extension. The reductions in the state payments, they don't start until I think 2029. So there's a little bit of a lag here, but this is what sort of projected over the last 10 years. So that's sort of the access to care bucket. Then rural health, of course, given some of the implications related to Medicaid, lots of concerns there about hospital closures, access to care, maternity care, behavioral health care, a suite of issues. And then prescription drug costs. And this is tied to the administration's economic policy, tariffs, sort of arm twisting of pharmaceutical companies. I think we've seen some of the recent press reports of, particularly actually last week with Novo and Lilly about GLP-1s, which we ought to talk about. And then international reference pricing, or what currently is being called most favored nation, that we ought not to as a country be paying more than what other countries are paying for the same pharmaceutical drug. And we can certainly talk about that issue more. So I want to just sort of end before we get into questions about my thoughts. Given the landscape, what do I see as perhaps opportunities in health policy? What are the things that we got to mitigate against? And what are the areas, third, that there's just going to be silence, particularly at the federal level? But that means that it's incumbent upon sort of all of us to continue raising these issues. So actually, let me start with the mitigation piece. I think vaccines are there. We face a twin problem, both in terms of, and a lot of this is COVID spillover effects, but we're going into respiratory season now, COVID, flu, RSV, and this is a big issue, and this is a big challenge. You're seeing a lot of states saying what we're getting from CDC and the administration is not evidence-based. We're going to make our own recommendations, and so I think that's an issue. And then on the other hand, childhood vaccination rates continue in many cases, in many states, continue to decrease, increase in exemptions as well. I think we're seeing that here in the state of Michigan. So sort of twin issues there that we need to continue providing the evidence for that for the foreseeable future. Unfortunately, we have to fight this battle, but it is a real battle when it comes to misconceptions, misperceptions out there. Medicaid and ACA, as I said, I think one of the things that has to be mitigated, and we're going to need to ensure that people, either don't fall through the cracks, don't lose their health insurance, or at least have a usual source of care, is this fact that we're likely going to see more people who are uninsured over the next several years. So that's sort of the Medicaid and the ACA piece. And then SNAP, we've talked a little bit, haven't talked as much about SNAP, but it's projected because of the One Big Beautiful Bill Act that there'll be a reduction of $186 billion over 10 years for supplemental nutrition assistance for the 40 million people who depend on that for food security and nutrition security. And we know that that's also been linked to improvements in health outcomes. So all of these areas are ones where we need to mitigate either with how we partner with communities, how we spend as sort of a health system or community benefit dollars, how we educate the public about the importance of vaccines. So that's sort of the mitigation piece. Where there are potential opportunities. So I think, again, poor diet is now many consider the leading risk factor for mortality in the United States. I think nutrition has to be an opportunity. I think we have to move away from the focus on some of the niche issues that we've been hearing about and really focus on how do we increase nutrition research? How do we increase health professional training for nutrition? How do we focus again on sodium, added sugar, saturated fat, the elements that are driving chronic diseases? How we continue to understand what processing means, what ultra processed foods mean, definitions, research there. So there's a lot on the nutrition front that I think there are opportunities there. Primary care as well. I think there are opportunities if you look at what CMS just put out in terms of their final rule for Medicare of payments to providers. And there's beginning to be a recognition about the important evaluation and management role, how much time and effort primary care clinicians, whether it's internists or family docs or pediatricians, spend in doing that important work and valuing those services at the level that they ought to be. And so increasing primary care spend in different ways, I think, could be an opportunity. Rural healthcare I placed here because some of you know, given the concerns about what could happen to rural healthcare and access in the One Big Beautiful Bill Act, they passed a $50 billion rural healthcare transformation fund. All states have applied for those funds. All states are going to get $500 million at least. So that's $25 billion. The other $25 billion is based on a number of different criteria. So we'll see how well Michigan does there, but an opportunity to sort of, of course, with fewer resources, and I think hospitals are quite concerned about this, but an opportunity to sort of reimagine rural healthcare there. So a few opportunities, I think, for all of us to think about. And then I think, again, this third bucket, I just sort of called it ongoing vigilance, because I don't think we're going to hear a lot about these issues, many of which, health equity is sort of at the center, but the public health infrastructure, which is being dismantled, particularly concerns at the federal level, but most of what state and local public health get comes from CDC and the federal government, whether it's CDC or HRSA or other agencies. The best estimates are that we have a $4.5 billion annual gap in ensuring that all health departments have the foundational capabilities to assure the conditions that populations can be healthy. So that's everything from doing assessments and surveillance and having laboratory capacity. And so that's a huge gap. And now public health is taking an even greater hit. So the public health infrastructure, obviously an area of concern. Violence prevention, firearm violence prevention. I don't need to tell this audience about the importance of that, particularly for children. But again, Unlikely, at least we haven't heard anything yet. There was nothing in of course, the MAHA report about violence prevention, firearm injury prevention, maternal health also. Unclear whether we're going to hear a lot about that, whether there's going to be focus. Overdose prevention, treatment, and recovery. You know, I worry about agencies like SAMHSA that have lost a third of their staff and billions of dollars of funding, and how without that federal leadership role, certainly there are settlement funds that states have, but how we're going to continue making gains in preventing overdoses and treatment recovery. Tobacco use, smoking cessation, still again with poor diet, you know, the leading risk factor driver. We've done, you know, seen terrific progress amongst children in terms of reductions in cigarette smoking, but still with respect to adults and also sort of children's as we look at e-cigarettes and others. So lots of things to do there, but concerns at the federal level. So at CDC, their Office on Smoking and Health disbanded. At FDA, their Center for Tobacco Products, their leadership gone. So less focus on tobacco. We haven't heard a lot of that in the MAHA agenda as well. And then certainly pandemic preparedness. And you know, at the Bipartisan Policy Center, we fought hard to ensure that post-COVID, there was an office in the White House focused on pandemic preparedness, got bipartisan support, and there's supposed to be a new office there. Wasn't staffed by anyone other than one individual who recently has left. So there's really nobody focused right now on pandemic preparedness and response at sort of the highest levels of government, which is obviously very concerning. We know that when it comes to pandemics, it's not a question of if, but when. And it's so important that both on the surveillance side as well as the therapeutic side, you know, these are things really at the federal level, you know, have to be done. And there's concern that they're not being done. So I think these are all areas where, again, we may not hear a lot, but they're absolutely critical when it comes to population health and ensuring that you know, the population is protected and that we're focused on disease prevention and health promotion. So I think with that, I will stop there, and hopefully this was informative, and hopefully it's just a sort of a prelude to the Q&A and the discussion that we'll have, but really enjoy the opportunity to discuss this with all of you, and looking forward to Q&A. Thanks, everybody. Yes.
So I'd love to hear more about your slide a couple before the end, where you had the two columns, you know, the mitigation you talked about, and then the opportunities. It seems to me right there, yeah. So Medicaid, you know, the mitigation, I'd love to hear more about it, because it seemed to me like, well, not defunding Medicaid would be one mitigation strategy because of the tight connection with rural healthcare.
Yeah.
There are places, like we could start in Michigan, that are just directly tied to, and there are places that are already lost, the only show in town. So I'd love to hear more of your thoughts on that connection and strategies.
Yeah. So I think it's a big concern. A lot of our communities, so at least in Michigan here, we're 5 million people in urban areas, 5 million people in rural areas. And you're right. I think Medicaid, not only is it the largest payer in this country more broadly, but particularly for rural areas, it's a lifeline. So I think that's a really big concern. There is one exemption where if unemployment rates in particular rural counties are too high, then the Medicaid work requirements don't apply. And what's interesting, I think there was a KFF study that showed that Michigan is one of those states where actually that exemption could in and of itself be helpful. But I do think it's a really big concern when you have in a lot of these rural communities, the hospital in town, if there is a hospital, it's the biggest employer, and Medicaid is the most important payer there. So take Medicaid away, that not only from a health but from an economic perspective, and really a $50 billion transformation fund, that sounds good. It's not a lot of money, right? I mean, with 50 states over 5 years, you know, it probably only, I think the projections are, it makes up for maybe 15 to 20% of what the losses would be on the Medicaid side. So I think the question for every state, including our state, is how do you mitigate that? So on the work requirement side, how do you make sure that the systems we have in place, that people who are eligible aren't dropping off because of paperwork requirements? How do we make it easier? How do we make sure that there's systems in place where many times multiple people are eligible for multiple programs, whether it's SNAP, whether it's Medicaid? How do we make sure it's sort of one stop where they can sign up for multiple programs if they're eligible? How do we make it easier for folks? That's going to be a big challenge for every state, including ours. Now, we do have a little bit of a head start because we started planning for this in Michigan. John Anian and IHPI and team and the folks who were leading MDHH back in 2020, because there was at that time legislation in the state of Michigan to start imposing work requirements. At the last minute, I think there was a federal court case that overturned that, so we didn't have to do that. But I think the state has been thinking about that. I'm not so sure other states have been thinking about that. And if you look at Arkansas and other examples out there with work requirements, hasn't increased employment, and unfortunately, on the flip side, people have lost health insurance. So I think it's a big concern. I think it's a big concern on the rural side. I worry about the transformation fund not having enough dollars. I worry about reductions in access to particularly children's health, OB care, behavioral health, all the critical services out there. So I think it's a big concern. Other questions?
Can you talk a little bit about what you foresee for the research landscape? There's obviously been a huge amount of disruption, delays, people not getting renewals. How do you see that playing out over the next couple of years?
Yeah, so I do think there's bipartisan support in the Senate for retaining NIH funding levels. And I think the Senate has been pretty clear that when it comes to sort of, let's say, indirect rate policy, that the administration on its own can't do anything, and they want things to remain as things have. And if you look at the marks, actually both for the House and Senate, but particularly the Senate, NIH funding looks at least relatively pretty good. The question is, will the administration follow what Congress says, and will OMB in particular, what will they do? And I think that's the sort of the biggest concern when it comes to NIH funding, indirect rates, and the whole sort of process at NIH right now well, right now there's sort of a shutdown, but even prior to that, there's so much backlog there, study sections being canceled, rates of success going down. So I think there are lots of concerns there, but there is overall, I think, still bipartisan support for biomedical research, both sides of the aisle. The concern is what the administration unilaterally may want to do. So I think that's where my biggest concern is. Where are the opportunities when it comes to the research paradigm? I'd probably go back to sort of the MAHA agenda. So I think in some of these areas that the administration's talked about, there are likely going to be new funding opportunity announcements. And I think thinking through what we're already doing. So one of the things that I'm trying to do is try to university-wide understand, at least on these topics, where are our faculty and researchers already doing research, because there are a lot of important scientific questions in each of these areas, but just having that sort of inventory is helpful not only to enhance coordination and collaboration across sort of the research community here at U of M. It can help us get in the doors, not just with Democrats, but Republicans as well, if it's MAHA related. It can prime us for that next NIH funding opportunity announcement in one of these areas. So there are sort of multiple reasons why I think from a research perspective, I would sort of focus in on these areas and try to understand what are we already doing? Where can we provide policymakers with evidence and data on the questions they're asking? But what are the other scientific questions within these areas? Because I think it's more than likely, if we see new funding opportunity announcements from the federal government, they're probably going to come from one of these areas. Yes.
So I'm looking for some reason to be optimistic. So
I am as well.
So I study childhood asthma and environmental exposures, and at various times I've looked at physical activity and different nutritional impacts on that. So I look at this and I say, oh, yay, this should be wonderful for me and colleagues like me. But the pessimism comes on two fronts. One is, okay, we already know tobacco bad. We already know that Medicaid is an important funder of chronic disease management, and it sort of feels like the evidence doesn't matter in the policy anymore. So why bother is one concern. The other concern that sort of is circulating around in my colleagues' world is if we continue to do research under the aegis of MAHA are the results going to be co-opted, right? Are there going to be requirements for oversight, review, and are they going to cherry pick results? And are the conclusions that we would make from a scientific perspective going to be preserved? Are they going to be perturbed? So I'm wondering if you can help me feel better about the landscape.
Yeah, that's a hard question. I think we've seen, starting with the second question, already with their MAHA report and, taking results and sort of either them being sensationalized or being interpreted in a way where authors didn't intend them to be. And I think that's a concern, but that sort of connects to the first point as well, which is we have to sort of stay positive in that we have to continue building the evidence base. And even though policymakers aren't using that, there are a lot of other policymakers, right, at the local level, at the state level. And the fact is, politics, I mean, it goes through cycles, and this time also will pass, and there'll be new policymakers at the federal level. But I think sometimes we just focus at the federal level. And the other thing is, a lot of times, unfortunately, the research that we do, the translation piece, sometimes it's not, it takes time, right? And so the research we do now may not impact policy tomorrow, but it sure as well may impact policy a couple of years down the road. But now, even maybe it's not the federal level, but at the state level, I mean, there is a thirst for and you're absolutely right. I mean, I don't think asthma. I mean, how many times was it even mentioned, right, in the MAHA report? I can't even remember. But so you think you'd start with things like that, right? But so I would. I don't have a good answer to your question, other than we have to realize that federal policymakers aren't the only policymakers out there. There are lots of folks. And second, this too shall pass. And again, sometimes there's a bit of a lag between the research we do until it's applied. That's sort of just the nature of things. Yeah. Sorry. Yeah.
Great talk. I love this, phrase, "This shall pass." But having lived in a dictatorship before, back in Nigeria, some of the long-term effects of what is happening now could last decades,
yes,
centuries. So I just wanted to throw that out. The muzzling of academia, is very concerning. Let me give you a quick example. So we wrote this perspective right in the thick of the COVID pandemic, making it very clear that the National Strategic Stockpile, for one, a strategic national stockpile, did not have ventilators for kids. And made it very clear we knew what data existed at that point in time, wrote this viewpoint about all the issues related to children. Were they to get heavily impacted by the pandemic? Sent to one of the, prime journals in pulmonary medicine in the adult world. And it was essentially stymied by, after the second round of review, it was like, okay, we're going to send this out to a consultant. This was a government person, just to link with what you do. And the person came back, firing from the hip, that we have ordered 283,000 ventilators, blah, blah, blah. This was 5 months after the initial submission. And eventually said, this is a beautiful piece of work, but time has passed and it no longer needs to be published. As we try to build trust with the public, what is coming out of peer review when, for example, there was total oversight / micromanagement of MMWR during the first regime of this government? We are struggling with building trust with the public because I'll be honest with you, the evidentiary base that we're working on, the foundation for the evidence is shaken by mistrust. And I find it very difficult to believe that the public will believe anything we say at this point. So in your role, I mean, how do you break through into this very sort of fragile, chaotic, long-lasting negativism that exists?
Yeah. No, thank you for that perspective. And you know, I think you know, it's worth thinking through ways we can engage with people who may not on face value agree with us more, or ways where we can directly engage with the public, because the public's getting their information nowadays from social media or their cable, you know, their favorite cable news show, you know, or the administration when there's sort of misconceptions there. And so I think trust is something that's built at the end of the day, not from DC, but one community at a time through people that you trust, family, friends, faith, and others. And somehow, you know, maybe our small role is to better see if we can directly connect with communities. And, you know, I'll just give you one example. One of the things that we're thinking about doing is hosting some public health town halls across the state, right? So public health post-COVID has been totally politicized. How do we sort of take back what public health is? And you can, it's sort of the same, you know, whether it's a specific issue like children's ventilators or sort of the role of public health. Somehow I think we have to, with empathy, find opportunities where we're directly engaging with the public where they are, and going out of our way to have that dialogue, which we otherwise wouldn't have, which we, you know, usually we would say, all right, the science is such, and we produce the evidence, we're going to publish it, and it should be all good then. But you're right, we're not living in that world anymore. So I guess it's a question for all of us. How do we, you know, so I think about that a lot every single day when I come to those. How do I help translate the research findings from our peer-reviewed journals, from our faculty? Yeah, how do we get that in the hands of policymakers? But to your point, that's not going to be enough, because policymakers may not care. They may not listen. It may not align with their thinking. And so then the question is, how do you bypass them and go directly to the public? And even if you do that, how are we going to compete with the social medias of the world and this? So I hear you, and I think we need to think about it more. But somehow I think we need to directly connect with the public, and we need to. It's going to take effort, but I do think that trust begins one community at a time. It's not going to happen from DC. So, you know, it's worth thinking about.
So I want to. There's a online question from Dr. Brasser.
Yeah,
Yeah.
she has her hand up, so here she comes.
Okay, good morning, Anand. Thanks so much for that terrific presentation. And just to say, I'm with you. I'm taking the long view that I believe that there will be a time where evidence will be important in decision making again, but also in the short term that we do have many other decision makers that are really hungry for this kind of evidence. So one point that I wanted to make is that when we talk about prevention, there's often an inclination to group it all together, but I think it's really important to highlight that, prevention really varies widely, just like treatment, both in terms of effectiveness and cost effectiveness, which really underscores the importance of continuing to do the work that we do on being able to promote and identify, those strategies that are most effective and cost effective. And thinking about kind of where those partners might be. So this is my question. So in the short term, we see that AHRQ is essentially dead. CDC has been gutted, and those are the two federal funding agencies that have really supported the bulk of prevention research, over the past many years. And so where do you see over the next few years, because it, as always, takes years to develop this evidence, who can we look to partner with, for starting to work on these questions, in the meantime?
Yeah, no, thank you, Lisa, for those for those observations and questions. Absolutely agree with you that sort of prevention is a broad term, and depending on specific interventions in primary and secondary, I am always reminded, but again, the focus on prevention needs to be on improving health outcomes. It's not always sort of cost reductions, but Dr. Prosser is absolutely right that most prevention interventions are in fact cost effective. Some are actually cost saving as well. So specifying the interventions are absolutely critical. I think at the federal level, we need to, and I think you all are already looking at entities like PCORI, entities like ARPA-H, others that are connected to the federal government, but perhaps are not being it's all relative, as impacted by entities like ARC. I think what's happening at ARC is tragic. But thinking through where the backfill could be, again, whether it's entities like this, are there things that CMS could do? Are there things that outside entities can do? I think is important. I think CDC is more problematic because they're just so critical to the public health infrastructure in this country. It's not something that we can just say philanthropy can do this, or nonprofit partners can do this, and certainly I think all of them need to do some things. And there are a lot of things I have sort of a wish list that philanthropy could do at this moment, but I think it's a big concern. I think we're going to have to see where funding levels, Lisa, end up at this year for a lot of these federal agencies. So if you look at the president's budget, these are agencies that are being completely decimated. If you look at Senate marks, they're a lot better. So what is the ultimate number going to be? Is the administration going to follow that? I think those are going to be some critical things just for us to keep an eye out in terms of how bad is the research funding climate going to look. And I think we're going to probably know more in 6 months than we know now how this all shakes out in terms of where to look for resources. But in the interim, I think we're all thinking about what are the other places that aren't going to completely replace ARC and CDC, but where we might go to fund some of the promising research.
Hi, Gary Reed.
Yeah.
Thanks for your talk. I have one statement and one question. The statement is, like earlier you talked about how priorities are defined by our values a lot of times. And I think an important way that many of us in this room think about this is that there actually are different priorities for adults,
yeah,
and different priorities for children. And usually, historically in healthcare, the priorities for adults far push aside in policy, in government relations, whatever it might be, priorities for children. Whether that's, when you talk about preventable causes of illness,
Right.
all of those were adult focused.
Right.
None of those had anything to do with suicide or, birth defect, whatever it might be. And so I believe or hope in your role going forward, I'd like to challenge you to not, when things get lumped all together, kids lose. And that if we could consider having separate priority lists that allow those children's priorities, although financially and everything else are rounding errors to the adult stuff. Medicaid, right now, the issue is Medicaid, the Obamacare or the Affordable Care Act was Medicaid expansion. That had nothing to do really with kids, that was adults. And I know that that's important.
Yeah.
But there's different issues for kids for Medicaid that we don't necessarily focus on as much. That's my statement. My question is about your discussion of public mistrust. which I think is a big deal. Obviously, it's a big deal, and it's getting worse on a lot of pediatric issues that you mentioned, like vaccines, physical activity, stuff like fluoride. And that you made the statement that we can't win the battle, let's say at the federal level with regard to trust. But I would say actually we lost the battle at the federal level about trust. It wasn't at the community level. And maybe we need to think about whether or not there's an alternate strategy that we haven't employed, and I don't know what it is. I'm gonna depend on you in this role to figure that out.
Yeah.
That we shouldn't give that up, because having a town hall, even if we have 50 of them around the state, it's not gonna actually reach that many people. Like, to be very honest, we'll feel really good going to Detroit and having a town hall in, someplace in what neighborhood. But whether or not that is actually gonna address the issues of social media, whether that's gonna address other things, I'm not so sure. And I think, I think we should, I ask you to think about and perhaps comment on why we want to give up on social media, why we want to give up on the federal process or even the state level, and why town halls are our go-to strategy.
Yeah, no, thank you for both those. So just starting with the first, I think, putting the Maha slide back up, I think sort of in a crisis, there's an opportunity. So understanding if this is the agenda focused on reversing the children's chronic disease epidemic, okay, what are the most important issues within these 4 areas that we as a community want to elevate and influence in terms of policy or do more research on? I think that's something for us, and I think we ought to, and then also more broadly on the key children's health policy issues of the day. I think this is the time because whether the folks know it or not at the federal level who are in charge, if reversing the children's chronic disease epidemic is front and center, then we should look at this as an opportunity. And so I absolutely agree with you and thank you for that observation. I think on trust, and the town hall is sort of just an example, and I don't think that we ought to give up on sort of the federal level. I think it's worth us thinking through as we combat misinformation in this era. What is our role? Where can we have an impact? And it doesn't mean that we don't think big. We should, and partnerships. But maybe having a combination of things that are tangible that we can do with sort of bigger ideas, or if we're going to tackle social media and if we're going to, people want to ban social media, and look at the sort of the youth mental health crisis, then we got to have those conversations. And absolutely, and I am happy to help however I can. I mean, we just finished work when I left on sort of tackling the youth mental health crisis, and we had recommendations to Congress and states and others. So I think Gary, it's probably an all of the above strategy, and not to, as you're saying, dismiss levels. But I'm also sort of thinking about initially tangible things that we can do. But certainly I hope this is an ongoing conversation. So I appreciate that.
Thanks.
Great. Yeah.
So I just want to directly respond to Toby, your skepticism about the value of research in this environment. The MAHA initial assessment report actually cited 2 studies that I was involved in. One on antidepressant dispensing to adolescents, and one with Joyce, who just left, on GLP-1 dispensing to adolescents, young adults. And those were cited as examples of over medicalization, right? There's not a lot of context there. Just because something is going up doesn't necessarily mean that it's overuse. So yes, absolutely, there is some potential for research to be cherry picked. But there was actually, interestingly, a study that we were involved in that wasn't cited by the MAHA report, which was a study showing that stimulant dispensing to children has basically been flat from 2017 to 2023. That instead, what they cited was a study that basically from 2008 to 2016, using older data showing that stimulant dispensing had actually been rising. And after there was so that was interesting to me. Then I saw that. And then back in August, there was actually an editorial from Mark Olfson at Columbia, who's in GEM Pediatrics, that basically was pointing out some of the kind of facts, the cherry picked facts in the Maha report. And that one actually did cite the study that we had done showing that stimulant dispensing to children was actually flat, which is all a way of saying that, yeah, Mark Olfson is not a policymaker, right? Of course, but the facts do matter, right? That there are other audiences that do actually look at this, at the data, the most recent data. So I think it's just kind of just a general comment about, at least for me, this really underscores the need for us as researchers to continue to try to provide the most rigorous, up-to-date data possible to inform these kind of discussions, even if at the federal level, it may not be the message that we wanted to convey. There are other voices in the room that potentially can use the data that we provide.
Yeah, maybe I'll just sort of underscore that, sort of what Cal was underscoring, you know, IHPI and lots of resources here at the university, but we want to amplify sort of that data and research coming, those findings coming out of your research, and whether that then leads to op-eds, whether that leads to meetings with policymakers, but all of this, even though, you know, you wonder, well, will it matter or not? I think we still have to keep doing it, because if we don't do it, then even less people will know about that research or care. And so I think we have to keep sort of knocking on the doors, keep, you know, raising visibility about our research findings. And then it's also incumbent upon us to try to find the opportunities to connect you all with the right policymakers, or, you know, how do you get in front of the public in a way that's most impactful, thinking about sort of all the levels, and how do we tackle tangible things? How do we tackle sort of bigger ideas? So I think we need to keep on doing that. Yes.
Just real quick, so I help run policy for our subspecialty society, and one of the things that we've worked a lot on is figuring out exactly who to talk to.
Yeah.
And I wonder if you could comment a little bit on, you know, oftentimes one of our first questions is this something that can be changed in existing statute already, without having to go through either you know, a legislative process or not? And just wondering if you comment on, you know, who's getting the data initially, and whether that can change things right away or very quickly, rather than through either prolonged legislative processes or otherwise.
Anytime you don't have to go through Congress, the better. Anytime you can do things through sort of administrative capacities, through regulations, I think is important. I mean, just look at GLP-1s and coverage for perhaps Medicare, Medicaid. We don't know what's exactly going to happen, but because of the statutory definition from 20 years ago and weight loss considered cosmetic, CMS has not been able to cover these drugs for either Medicare or for the Medicare population. Medicaid sort of had a possible. So Biden administration decided, you know what, we're going to reinterpret that reg, and you know, Trump administration, if they want to do what they said they want to do last week, they're going to have to do that as well. So I think you're absolutely right. Whenever you can avoid going through Congress, given the dysfunction, you know, they've been shut down for 41 days, is sort of case example. I think the better. So just strategizing, can this be done administratively? Who are the folks there? And again, oftentimes we're all busy, so the press release goes out of our research findings, and then we stop because we just don't have the bandwidth. And here the idea is, how do you go beyond that and get that to the specific policymaker? You know, how do we identify that? Let's get that to them, and let's see if change can happen without going, you know, the legislative route. So thanks for sharing.
We're out of time. Thank you so much for